Now let's talk about the pathophysiology of eclampsia. So remember that if you talk about the pre-eclampsia, basically we know that that is just the elevation of blood pressure greater than 140 and greater than 190 diastolic and also systolic. Okay, we all know that. And basically pre-eclampsia is further categorized into mild pre-eclampsia and also severe pre-eclampsia based on those particular characteristics that we talked about. Okay, now what is the pathophysiology of pre-eclampsia? Basically it is postulated that there is some problem with what the trophoblastic invasion, as well as the remodeling of the the spiral arteries, which are the branches of the uterine arteries. Okay. So what are we saying? So if you talk about the pathophysiology, it's because of what? It's because of two important things. Failure of what? Failure of, so let's just say failure of trophoblastic invasion, and what else? And also failure of what? The spiral artery to be remodeling of what? Spiral artery. So failure of as well as what? Remodeling of spiral arteries. Okay, so spiral arteries, remember that those are just the terminal branches of what? The uterine arteries. Okay, so that's basically the pathophysiology of pre-eclampsia. And remember that for gestational hypertension, the pathophysiology is unknown. Okay, it is not yet postulated, although there are some maybe certain theories that are there. Okay, but for this one at least, there is a theory that because of trophoblastic invasion and also failure of what? Remodeling of what is spiral artery. Those are the two important aspects when it comes to that. Now, let us understand what happens normally in normal pregnancy on how trophoblasts invade the decidual part of the uterus and also the myometrium. Okay, so let's start with this. So we know that in the first trimester, basically starting from 10 weeks to 12 weeks, there will be the first invasion of what? The trophoblast. Remember that there are basically there are examples of trophoblasts that we need to know. There is syncytial trophoblast, there is the cyclotrophoblast, and there is also what? There is the endothelial trophoblast. The one that invade the myometrium and the decidual part of the endometrium are what? Which is the endothelial trophoblastic cells. Okay. So in the first trimester, there will be the first invasion, and also in the second trimester, there will be the second invasion. Okay. So in the first trimester, the endothelial trophoblastic cells, they start invading what? The endometrial, the decidual part of the endometrium. Okay. Then in the second trimester, particularly starting from 16th week up to 18th week, the endothelial trophoblast cells now they will start invading the myometrium segment. Okay, so what are we saying? If you look at this part, this part is the this is the maternal part and this is the fetal part. Okay, so let's try to remember that. So this is the maternal part, which is the first part which we're talking here. This is the decidual part. Okay, and below the decidual there is what? Myometrial part. Okay, this is the maternal part. Then on the fetal part, there are some parts that you need to understand as well. This is what? Chorionic villi. Okay. Okay, and what are these? These are what? We say these are endothelial trophoblastic cells. Okay, these are endothelial trophoblastic cells. And what we call this space? We call it the intervillous space. Okay. So those are the important parts that we need to understand. And the last one is this one, which is the what? The spiral artery. The spiral arteries. Okay, let's just say artery. Okay. So what we said is that during the first invasion, as you can see here, these endothelial trophoblastic cells are invading this antennal part. Okay, if they're invading, they do something to the what? Spiral artery. Okay, there is some certain substances to start remodeling the what? The spiral artery if they invade correctly and efficiently. Okay. That's in the first trimester, and up to the second trimester, which is starting from 16th to 18th week, they are going to start what? Again, producing some substances that are going to start remodeling the spiral artery into what? Normal parts, normal things. So the spiral artery is going to be remodeled into what? They need to be what? Widened up. So they are going to be widened up, okay? So that more blood can go to the placenta there, or to the fetal placental unit there. What else? They will become tortuous. Okay, and what else? That's because they are like, what can I say? There is high blood pressure because of being tortuous and widened up. The blood pressure is going to what? To decrease. Okay. Also, the blood pressure there is going to what? Decrease. The reason why? Because we need maximum tissue perfusion to the placenta. Okay. That's why the blood pressure has to be what? Low there. Okay. Now, we know that, okay, they become that and that. So what are the substances that is making possible the spiral artery to become widened up, tortuous, and the BP is going to be low? It's because of, we said, because of endothelial trophoblastic cells. Now, what are the substances that are going to be produced by the endothelial cells so that the spiral artery becomes things like this? So what are those substances? So these endothelial trophoblastic cells, they release very important what? Substances. Okay, what is the first one? We call it VEGF. Okay, VEGF, vesicular endothelial growth factor. Okay, what else? They also release this endothelial trophoblastic cell. They release another one, the PLGF. You can guess that one, that is placenta growth factor. What else? Also another one, transforming growth factor beta. Okay, so these, they are very important to what? To remodel the spiral artery so that they become tortuous and make the blood pressure to become low, thereby increasing tissue perfusion to what? To the placenta, or to the fetal placenta unit there. Now, what is the problem? What could go wrong if you talk about pre-eclampsia? Now, pre-eclampsia, we are saying there is failure of this endothelial trophoblastic cells invasion, and there is also failure of what? Remodeling of spiral artery. Due to what? If there is failure of invasion of that, okay, these endothelial trophoblastic cells, then there will be what? There will be low blood supply to the what? To the placenta there. If there is low blood supply to the placenta is going to experience what we call hypoxia. Very important. If the placenta now experiences hypoxia, it's going to produce some certain substances that are going to be antagonists of what? These substances that are normal, that are going to promote something that is very what? Good for a placenta. And what are those substances? Okay, so it's going to release this. Okay, due to hypoxia, the placenta now will start producing what? It's going to produce this one, the soluble. Okay, the soluble form, like tyrosine kinase 1. So it will release that one, the soluble form like tyrosine kinase 1, okay, which is also abbreviated as SFLTK1. Okay, this is a very important substance that is released when someone when the pregnant woman, the placenta is experiencing what? Hypoxia. Very important one. Now, what does it do? This same thing, it is the antagonist to this. So it's going to start what? Antagonizing the VEGF production, or it's going to bind to VEGF, and it will also antagonize what? The platelet like, the placenta like growth factor. Okay. What is the other substance that's going to be is going to be released because of hypoxia? Apart from the soluble form like tyrosine kinase 1, there is also another one, important one. An important substance that's going to be released is what? We call it endocrine. Endocrine is also an important hypoxic substance that is produced by the placenta due to hypoxia. And what is it going to do? It's going to antagonize now this one, the transforming growth factor like beta. And these substances that we talked about, these are very, very good in what? Spiral artery remodeling. But if they are going to be antagonized by these two important things, now there will be what? Now there will be no tissue perfusion to the what? To the placenta, leading to more what? Hypoxia. Okay. Now since we know that, now definitely if you don't have VGF, you don't have PLGF, you don't have TGFB or beta, now there are some things that are going to be happening in the what? Maternal blood. Very, very important. Okay. What are those? So remember that this is the blood vessel of the maternal. Okay. Now what's going to happen due to this? If you have decreased VGF, so let's just pick one example. Decrease production of VGF. Now remember that now what's going to happen is that VGF, now it will start promoting what we call like anti-angiogenic factors, like what? So it if you see there is what we call prostacyclin or prostaglandin I2, prostaglandin what? I2, remember this, okay? And also there is what we call thromboxane 2, okay? Thromboxane 2 and prostacyclin, these are two substances that have what? Opposite actions, okay? Remember that prostaglandin I2 promotes what? They promote what we call vasodilatation of blood, okay, leading to what? Low blood, like decrease in the peripheral vascular resistance, leading to what? Low blood pressure, okay? That is the prostacyclin I2. Also, if you look at the nitric oxide also promote what? Vasodilatation of blood vessels, leading to also what? Low blood pressure. Now, if you look at the thromboxane promote what we call vasoconstriction, which in turn increases the blood pressure because it's going to increase the what? The peripheral blood resistance. Okay, very, very important. The other important thing about thromboxane is what? It promotes platelet aggregation. Prostaglandin or prostacyclin I2, that is what it promotes what? It inhibits platelet aggregation. Okay, apart from thromboxane, what else? There are a lot of substances of vasoconstrictors like angiotensin 2. Okay, so let's put angiotensin 2. Angiotensin 2. They will be in the endothelin 1, a lot of them. Now, what happens is that if you have low VGF, you have low amount of placenta like growth factors, transforming growth factor beta, because of these two important substances that we talked about, it will lead to what? Low production of what? This prostacyclin, because VGF is important to produce prostacyclin and nitric oxide. Then you're going to also have low amount of that. Then what's going to happen to this? This one is going to shoot up, and also these ones are going to shoot up, leading to what? Remember that what is the end product of what? Thromboxane 2 is to what? Increase the what? The peripheral vascular resistance, increasing the what? Blood what? Pressure. Remember, what's the formula of blood pressure? We know that the formula for blood pressure is nothing but equal to, we know that is the cardiac output plus what? Peripheral vascular what? Peripheral vascular resistance, PVR. Peripheral vascular resistance, or peripheral systemic vascular resistance. Now we are saying to say, if you increase this thromboxane 2 and angiotensin 2, they're going to increase the what? Peripheral vascular resistance. As you can see, if you increase the peripheral vascular resistance, you're going to increase what? The blood pressure. Increasing the blood pressure, basically that will be now hypertension. Okay, that is hypertension now. So that's how it will lead to what? Hypertension. Then apart from that, remember that if there is hypertension, remember that there will be also endothelial damage leading to more what production of cytokines that will also promote what hypertension. Okay, those are the main things that you need to understand about the pathophysiology of what pre-eclampsia. Okay, this same pathophysiology, it will lead to what? The other important aspect that you need to understand, because of that hypertension, if you look at the kidneys, so I'll talk about the kidneys because these are the main important, this is the main important organ that you need to know, because if you look at pre-eclampsia, we talked about the protein, one of the triad that we talked about, okay? The proteins has to be what? Released from the kidneys, and you find that in the 24-hour collecting of urine, you find about 300 milligrams of what? Proteins. In case of what? Mild pre-eclampsia, 5 grams of what? Proteins in urine collection in case of what? Severe pre-eclampsia. So let's talk about the kidneys. It's because of the problem is that it's because of the what? Endothelial damage of what? The kidneys there. So there is on the glomerulus there will be what? Increased permeability of those what? Blood vessels, leading to what? Escape of proteins from the what? From the blood, which is basically the albumin. Okay, so what are we saying about the kidneys? So these kidneys, okay, these kidneys, they are going to have what? Low blood there, okay, and since there's no blood, there is a vasoconstriction of these blood vessels from the kidneys, then there will be what? Endothelial what? Damage. If there is endothelial damage, what's going to happen? There will be increase in the what? Endothelial permeability. So increasing the what? Permeability. Increasing the permeability of endothelium there, it will lead to what? Escape of what? Escape of proteins. Like what? Albumin. And that's the main reason why you see someone with pre-eclampsia, they're going to have what? Protein in urine because of endothelial damage, because of what? Because of the hypertension that we from discussing the pathophysiology, okay? Yeah, so that's about that. Then what are the complications of pre-eclampsia? Remember that the complication of pre-eclampsia, there are a lot of complications, but basically under obs and GAN, make sure that you categorize them into maternal complication and also fetal complication. Under maternal complication, remember that you are going to have a lot of things. There will be liver hematoma, okay? That's the first one. What's the second one? There will be what? HELP syndrome, which is characterized by what? Hemolysis. There will be elevated liver enzymes and what? Low platelet count. That is HELP syndrome. Okay. What else apart from that? There will be acute. If you talk about the kidneys, there will be AKI, acute kidney what? Failure. Okay. What else? There will be DIC, which is disseminated intravascular what? Coagulopathy. Those are what? Maternal features. Also, the other maternal feature or complication that is very, very important, it can also lead to what? Eclampsia. Eclampsia basically is that's the seizures that are going to be happening. Basically, they are like tonic-clonic seizures like that. So what is eclampsia? Eclampsia is just a seizure that's going to happen someone with what? Pre-eclampsia. No wonder in the first video or in the first place we said pre-eclampsia, eclampsia. If someone is having a seizure and a pre-eclampsia, basically they are having pre-eclampsia, eclampsia. Okay. What else now? If you look at the fetal complication, what are the fetal complications? But basically they are just not a lot. There will be now fetal growth restriction. Okay. What else? There will be fetal demise. Okay. Yeah. So and also there will be there will be also malpresentation of the fetus as well. Okay. Yeah. So now in the next video, we'll talk about the management of what? The pre-eclampsia.